So we will get started, and just know that we will be watching the chat and taking care of questions that come up. We will hold our questions kind of to the end. I believe that's what we agreed to. So with that, I'm anxious and excited to introduce our speakers today. I will not go through a long bio of theirs, as we've talked about. The bios are in the information in the app, so you can access those there. But this is a welcome to, first of all, I guess, welcome to the Disruptive Partnerships track. It's often disruptions really kind of often force us to really look at our world differently. And disruptions come in a variety of formats. Certainly COVID was a disruption for us all this year, but disruptions come in even more subtle formats as well. And we're going to kind of talk a little bit about both the COVID focused disruption that happened, and then also a disruption that happened more from the perspective of policy, and kind of how some partnerships came together in a fairly unique manner. Jess is with Gundersen Health, Jessica Easterday, and she is going to visit with us first about kind of some of the disruptive partnerships that happen even within your own organization. So Jess, I'll turn to you, and we'll come to Michael next.
Excellent, thank you. Let me pull up my presentation here, just one sec. Okay, awesome. Well, thanks everybody for joining our session and taking up your lunch hour if you're in Central Time, or I appreciate you joining us today. I'm from Gundersen Health System in La Crosse, Wisconsin. And this is a picture of our main campus in La Crosse. This area is known throughout the region as the driftless region. We were not touched by glaciers, so we are surrounded by bluffs, high bluffs, and very deep valleys. We're also bordered with the Mississippi River. So that's what you're seeing in the background there is the Mississippi. We are located in 3 states, so Wisconsin, Minnesota, and Iowa. We're a physician-led organization, and we have 6 critical access hospitals, along with a multitude of clinics. We also partner for various functions with independent facilities throughout our region. This map shows our primary service area. So outlined in the orangish red here, you'll see what our primary service area is. The inner circle, and the circles are a little hard to see on this map, but is 25 miles. About 125,000 people live within that 25-mile radius of La Crosse. And most people within that area are going to seek primary care at one of the facilities in La Crosse. Outside that area, so we're talking 25 to 75 miles, you're looking at about 480 to 500,000 patients. So those patients are more likely to seek care in a facility or closer to their home. So that's really the focus of what our telemedicine program started at Gundersen, is really getting our services out to the region, and how do we meet those patients. So our first telemedicine program started in 1994. This was grant funded, and we built our own telemedicine cart here on site, and we saw a few burn patients at that point. Telephone Nurse Advisors was a triage service that started in 1995. And then things kind of just sat there, and we learned a lot about technology and the different policies of the time. By 2005, our telemedicine program officially started, we had 2 service lines. We had oncology and cardiology. And they were doing telemedicine to our furthest away critical access hospital at that time was in West Union, Iowa. We were still custom building our carts then, and that did not change until 2012 when we started to purchase telemedicine carts. 2015, carts were standardized. We were purchasing, they were the same throughout the region. We had about 20 different locations we were doing telemedicine to. 21 different specialties by 2015. We also started some asynchronous telemedicine with e-visits at that point. By 2018, we had 40 specialties that were participating in our telemedicine program. So really seeing quite a bit of growth with our clinicians being excited about it. We're seeing more patients from the region also asking their providers to do telemedicine. We started on-demand telemedicine visits in 2019. And then in 2020, everything changed for us. So if you remember that timeline from the last slide, here we are in 2020. And we had March 18th, we had our surgeries and procedures were going to be declining. The 20th, clinic visits were reduced. By the 23rd, we were transitioning everything to phone visits. And by the 25th, we were already starting to plan for how we were going to transition our patients to video. So this was a really fast, rapid transition of care for our staff throughout this 2-week period of going from March 25th of planning meetings to April 9th. Our first departments going live on video. So if it was really disruptive for our staff, so we're talking staff has been sent home. They are, we're trying to figure out what kind of equipment we have. What do we need? Can we even get it because of all of the supply chain issues that were happening? How are we going to get 600 video monitors here before our go live? So it was a pretty insane time. We worked really closely. We had a really great core team of people who worked on this initial video project, partnering with our IS team, figuring out what solution did we have in-house that could that we could use. And that was our initial solution was Skype for Business because it was something we had access to. So imagine all of this disruption happening for our staff. It was equally as disruptive for our patients. So patients were feeling really unsure. The scheduling was really cumbersome. We're now sending links to their email address, and some of our patients didn't use email very often, or they didn't know how to filter their emails or search for this invitation that was supposedly going to come. But oh, by the way, it might go to your spam folder. Oh, I don't have a spam folder. I have a junk folder. Well, look in your junk folder. So really we had to look at, all of these different layers of problems that were coming up for our patients. So, and our patients weren't always confident with their own technology, their own ability to use their technology. They're like, I always use the analogy of my mother-in-law who said, I have a smartphone, but a dumb user. And those are her words. So, just because she has a smartphone doesn't mean she knows how to access and use all of those features of that smartphone. So these are things that we took into consideration in forming a group. We decided we needed to form a customer service team that was really focused on addressing our patients' needs in this transition to virtual care. So brainstorming, what skills do they need to have? Well, they need to be friendly. They need to be patient. Our patients are going to be stressed out, so they're going to need to have a thick skin. They're going to need to be adaptable, because basically we're going to build this on the fly. We're going to build this plane as we're flying it. So really needing to have that adaptability, and ability to speak up and identify issues and potential problems. From the technical requirements, we wanted them to have access to Epic. So they needed to have the ability to go into a patient's itinerary within their EHR and identify where the appointments were supposed to be happening, so they could help track possibly when these emails would be sent out, or be to help the patient find them in their own inbox. We wanted them to be familiar with our health system, and also have some previous registration experience. So we took this list of requirements and we met with our HR team. Now, remember, half of our departments were, laying people off, furloughing, or people were on a reduced schedule. So we didn't know what we were going to have available to us for any resources. So we met with HR, showed them this list, and said, who do we have within the organization that would fit with these, what job description would fit this? And it was our patient access registration specialists. So these are staff that had previously been working in scheduling, kind of behind the scenes scheduling, taking a lot of phone calls, doing problem solving, and informal leaders amongst their department. So they were either furloughed or on reduced schedule. And really, they had that ability to communicate. And so that's exactly the team that we were looking for. Now, these aren't technical people. You didn't see any technical requirements or that they had any type of certifications with IT at all. So we partnered with our help desk, because those are people who are focused on what is the intake and how do I triage it to get patients or get people to a solution. So our help desk was really integral in helping us create technical guides and troubleshooting guides for our customer service team. So they made step-by-step instructions, things like how do you install and uninstall a program, screenshots of different icons, so that our customer service team, using their skill sets of communication, would take these troubleshooting tips and turn that into a very layperson terms. Instead of click on the microphone, it would be, do you see the oval thing that looks with a slash through it? Click on that. Or so really turning these troubleshooting tips into usable information for our patients. So here's our customer service team. We went live on April 23rd. So within 2 weeks, we had 5 staff that started with us. We're down to 4. One got called back to a regular department, but we still have 4 of these staff, and this is on their go live date. This is pre-mask requirements. So we were all 6 feet apart in this room, and this was their initial training day. So they're all smiling. So we were all happy that they were smiling at the end of the day, and we're able to take a picture. So this group over time, because they've been through our, they helped build this, and the tools that they're using really has bonded as a group. They use each other, they use their IS help, and have really helped us to identify a lot of problems so we can fix these before the actual appointments happen. So with our initial implementation of our COVID response, shortly afterwards, it was decided that video visits was going to be a long-term solution here at Gundersen and was going to be integrated into the type of care that we deliver on a daily basis. So we began to search for a new platform. And so this was going to be yet another change for our patients. So our new platform needed to have a few criteria. One in particular was access for our patients through MyChart. With our digital transformation here at Gundersen, pushing patients to use MyChart for things like their lab results, their prescription refills, how do I message my doctor, how do I pay a bill, and how do I access a video visit, all happen through MyChart. Now, so this team will help to activate MyCharts. They will also help to reset passwords if patients may have set up a MyChart. What we've learned was they set up a MyChart account 6 years ago, but never used it. And so they needed to reset their passwords and things like that. We prepare patients for their experience, give them some tips on what to expect. We help them with their personal devices. We communicate with departments and clinicians at the time of appointments if a patient is having a hard time getting in. And we're always maintaining a positive attitude and that confidence that that will encourage patients to seek care virtually. So a big thing is the setting the patient up for success, and that happens at the time of scheduling. So there are some key things that happen at that time of scheduling. And this is something that we learned along the way. It got a little, with our first platform, people became familiar with it. People were having more than one video visit, so they got used to it. We got a little lax. When we went live with our long-term solution platform in February, we had to revisit some of these handoffs that occur between departments. Again, we want these things to mimic an in-person visit as much as possible. So therefore, we want similar handoffs to be happening. So when a video visit is scheduled, our scheduling staff will give a few tips. Like 4 or 5 things, like your appointment with Dr. So-and-so is a video visit. Do you have access to the internet? That's number 1. Do you have a MyChart account? If these things don't happen, then can they get to a place with Wi-Fi that's private and secure? Or can we send them a quick link to get them set up for MyChart? If the patient cannot do it at that time, if they say, I really want to do this, but I don't have time right now, we can send the virtual care customer service team a in-basket message. And so this is a screenshot of that in-basket message. But also the scheduling staff is directing patients to where some tools are. So within MyChart, we have some troubleshooting tools to how to prepare for the video visit. We also have videos and different learning methods that depending on how the patient learns, some want to do this on their own and some would like to be guided through it. So we can offer any and all of that support. So we show them screenshots and things like that of how their video visit will look, because that reduces anxiety about they don't know what the screen is supposed to look like. So patient will complete e-check-in, which goes through all of the requirements of the legal and policy requirements for the video visit. We verify what state they're in because long-term, right now we have some flexibilities, but that's not always going to be the case. And Michael will probably get into that more. They also do their blanket authorizations on that day too. For troubleshooting, we've developed a tool called a symptom checker. So if a patient wants to just be prepared, they have the opportunity to click on the button that says, I want to be prepared. Or if they're joining last minute, which at times we know that some people don't join 15 minutes early and they join 5 minutes early, and they may have a little trouble with the platform. So if they're having trouble currently, they can click on that button. They go through the troubleshooting report or the troubleshooting things, and we're checking for their microphone, we're checking for their browser, we check for their internet speed, and this produces a report. This report is available in Epic and it's under the questionnaire section. So very easy to find for most of our clinicians or for our virtual care customer service team. So if the patient gets connected to the customer service team and says, I can't get connected, I don't know what's wrong, they can pull up this report and find out exactly what area of failure, where the failure occurred. In this case, the browser was wrong. So with our platform, we need to use either Chrome or Safari. Some patients prefer to use Edge or one of the other platforms that just aren't compatible with our platform. So we provide them with either written materials to change their browser, or our customer service team will walk them through how to change their browser real time. We provide assistance with personal devices. There are a multitude of personal devices. I just took a few screenshots of some of the reference materials that our team uses. So we have things from Windows to iPhones to Android phones. Most of our patients are connecting on a smartphone. So our team is very skilled with how to use an Android and how to use the iPhone. In fact, usually they're using their own devices as they're guiding the patient through which buttons to push. So as far as data collection, it's been fairly, I want to say, primitive at this point. We are collecting daily logs. Our team has been super important in identification of themes of problems that we're having for our patients. What tools do our patients need? So they really are integral in building their own program, because they are identifying the issues that then we can take it to the team and help to solve and provide tools for. So some of the themes that we see is I can't get connected. So connectivity issues. Whenever you talk about connectivity, that means a lot for a lot of different things. It means I can't get connected, or I don't have internet. There's, so you're going to solve those problems different ways. So connectivity is a broad issue. Bandwidth, of course, living in the driftless region, as I mentioned earlier, we do have internet issues here. Our patients live rurally. We are a rural health system, and many patients do have inadequate bandwidth. Some of our internet service providers, the max they offer is 6. So that's on a good day with perfect conditions, and we know that doesn't always exist. Going back to my mother-in-law with her infamiliarity with the personal device. So she has the device, but doesn't know what all the features are and how to activate them and how to go into the settings and change settings and allow for audio video connections to occur. There's a lot of fear of allowing for too much access to their device, because we hear about different people with bad intentions that might get your information, and certainly many of our patients who are seeking video visits at this point are elderly, and they have a big fear of allowing the access to these personal devices. So letting them know how to change it and how to change it back if they at the end of their visit is helpful. just being unfamiliar with the change. Even though communication was what we thought was adequate, communication to our patients needs to happen in many, many forms. So there was some unfamiliarity with the change, and that, you know, we were documenting all of these things because it's going to help us learn and how to the next implementation and how that can get better. So these logs are being kept on a daily basis. Each call is logged right now on an Excel spreadsheet, and then the themes are identified and solved. But coming soon, as our COVID response morphs into what our long-term plans are, we are going to be using the same intake as our help desk, doing ServiceNow and logging all of our calls just like the help desk would. So instead of just, you know, we have our internal help desk, we also have this customer service team that's our help desk for our patients. So they're going to log all of these issues, and we'll be able to pull all of this data from these logs. This will also help us to be able to identify where the issue is occurring. So if the issue is occurring with a particular clinician or provider, we can deploy our help desk to help them. If it's with their computer, their microphone, their keyboard doesn't work, those kind of things, that's our help desk will help with that. We may need to engage our vendor, and a ServiceNow, this will help to get that information to our vendor. We're also adding another layer of support in virtual care specialists, which will be providing education and training to all levels of staff, as well as looking for new opportunities in the virtual care field here at Gundersen. So lots happening, seeing a lot of disruption, a lot of change over the last year, and there's only more to come. So we're hoping to make it as smooth as possible for our patients. So thank you for your time and attention.
Yes, thank you very much. But very creative thoughts and solutions to some challenges that I think many organizations have been facing over this last year. We're going to kind of switch just a little bit in our thought process here now, and instead of it being a disruptive solution internally, we're going to look at disruption and the disruption from the perspective of partnerships, and how partnerships don't always have to be internal or even amongst the folks that we have consistent and solid working relationships with. They can be certainly from across a variety of organizations. Michael Richards is with the SSM Health and has been involved in the implementation of the Interstate Collaborative, which is a group of disparate organizations from across a variety of states. And Michael, I will turn it to you to kick us off. You will need to unmute.
I have to stop sharing and then getting over to my screen, so I apologize for that. Mary, thank you for the introduction. Thank you to the Mid-Atlantic and the Great Plains Telehealth Resource Centers for the invitation to share kind of the story about the Interstate Healthcare Collaborative, who we are, what we do, and why it's important. I think when we talk about disruptive partnerships. I'm going through my screens a little too quick here, so I apologize. So as Mary said, my name is Michael Richards. I'm the System Vice President of Government Affairs and Public Policy at SSM Health. For those that don't know, SSM Health is a very large Catholic integrated health system headquartered in St. Louis, Missouri. We have a lot of facilities in St. Louis Metro, ranging from children's hospitals to Safety Net and other hospitals, to Southern Illinois, which is right across the metro, right across the Mississippi River, kind of in the metro area. We also service Oklahoma City and a lot of the rural regions through affiliate arrangements with Oklahoma hospitals, as well as in Wisconsin, where we have an integrated health plan, 50-state transparent pass-through PBM. And then we service also kind of the metro area of Madison, but also getting into the rural areas of Wisconsin as well. So we have a very diverse makeup in terms of our organization. We have 40,000 employees. We have both employed physicians, and we also have others that we contract with to provide services to our patient base throughout our regions that we serve. And so I'm going to talk a little bit about the Interstate Healthcare Collaborative, who we are, why it's unique, how did it start, and give you a little idea of some of the flavor of the work that we do. So as Mary said, our group is made up of a whole host of different partners. We have traditional organizations such as Gundersen Health System is one of our members. So the integrated healthcare systems like SSM, like Gundersen. We also have healthcare organizations and associations such as, the Utah Hospital Association or the Wisconsin Medical Society, or separate clinics, groups that are interested in kind of telehealth around licensing issues. We have large associations in Washington, D.C., and even coalitions that have been built up around telehealth and around licensing that have all found this group to be kind of a nice group to get information, share resources, and understand a little bit about the policies that we're facing. How we got started was pre-COVID, and I appreciate Jess putting the map up of Gundersen. It started when I worked at Gundersen Health System. I was the executive director of external affairs. And so about 8 years ago, we started this organization, and really I shared a copy machine with the credentialing department. They came to me and said, I asked them how their day was going, and they had said, well, it'd be much easier if you could change the laws around credentialing. Because if you go to the hospital in Gundersen, the picture that Jess had showed of the campus, in the hospital, I could look outside the window and I could see Minnesota from Wisconsin. And if you went up to the helicopter deck, you could actually see the smokestacks in Iowa from that location as well. So when you're thinking about doing care and you're trying to do not only outreach, you have to be licensed where the patient lives. And especially when you're doing telehealth, you have to be licensed where the patient lives and is seeking that care. So trying to weave through some of those, or trying to, maneuver through some of those regulations and getting providers, specialists, or even primary care license was hard work. It took a lot of time and effort. Could take 7, 8, 9, 10 months. And if somebody had maybe something on the record, it might even take a lot longer than that. So we started having a conversation about how do you get people licensed a lot quicker? How are you able to provide care where they are, where our patients are? And so we started talking about interstate license compacts. We knew that a federal one-size-fits-all probably wasn't going to be the solution. A lot of states were going to push back. They currently license at the state level. And we wanted to make sure that we gave states some flexibility on scope of practice, gave them some other flexibilities on the license in general. So we convened a meeting with like-minded health systems in a basement of an Italian restaurant in Edina, Minnesota. And it was, I think it was Sanford Health at the time. It was Gundersen, it was Mayo, and a couple other health systems that had come to the table, really starting to talk about what would it look like to have an interstate medical license compact. And that was really our focus at the beginning. Our focus was around that physician compact, making it easier for them to move from state to state without having to go through a 6 to 7, 8, 9, 10 month process of getting licensed. And really from that time forward, this group started to have regular phone calls. We started to have regular meetings, and my colleagues who have run this over the years have held many meetings, many consulting discussions with hospitals, with associations about, how do we move interstate healthcare collaboration and compacts from not just the physician-led not from the physician standpoint, but also other compacts as well. So this is what we started with. When we started this in 8 years ago, we had no states. I think our first states that ended up getting passed were in the upper Midwest. I believe South Dakota, Utah were some of the first states that were able to pass the compact. And since that time, as you can see in the dark blue states, those are all states that started the compact. So if I'm in Wisconsin, I'm a physician, I have a clean bill of health, and I'm licensed there, I can apply to be in the compact, and then I can provide care in all the other blue states if I choose to have them have a license in those states. It's a one-stop shop. It's supposed to be a lot quicker. It's supposed to allow for people to move around states a lot easier. No, it did come with challenges. We ran into background check issues in Minnesota, where the FBI background check that they used wouldn't allow them to originate the compact license there. So we had to work around that over time. But as the interstate license compact reached 7 states to start with, we worked with the Interstate Medical License Compact Commission on comments on how the licensure should work. So we worked directly internally with our partners in credentialing and provided that feedback. And today I'm very proud of where we are today. As you can see, we have not only the dark blue, but the second darkest blue, other states that are now entering the compact. And we had a hearing yesterday in Missouri on a bill that would allow for us to provide that compact in Missouri. We're excited. Being from SSM, we have Missouri, Oklahoma, Illinois, and Wisconsin. We hope to see all 4 of them fully operational in the compact, which would allow us to do a lot more as a healthcare provider. Okay. So as we progressed over time, we saw that there was a need, and the second need was also nurse licensure. Being from St. Louis, Missouri, for those familiar, right across the metro is Illinois, and about 30% of our business comes right from across state lines. Same with Jess and at Gundersen. They're right on the border on the Mississippi River between Minnesota and Iowa. A lot of people flow back and forth. They don't always get the care, or work in the same state that they or live in the same state that they work. So it's important for us to be able to have nimble workforce moving back and forth between state lines. And as you see, the Nurse License Compact has generated enough momentum and steam. We are having conversations during our call with updates on the states and some of the roadblocks that they're facing to realize the compact in their state. We didn't stop there. What we've seen is other groups started to pop up. Now, this one has not been activated, but this is the Advanced Practice Nurse Compact. As you can see, there's 2 states that have been activated in the compact, but the compact itself has not been activated. It needs 7 states before it can start to generate a multi-state Advanced Practice Nurse Compact. Why is this important? As we know about telehealth, not all telehealth is done by a physician. It's also done by advanced practice nurses as well. And so as we think about doing telehealth and we think about doing more multi-state, getting people to be more nimble, again, you could be sitting at home someplace in Illinois, but you may be doing a telehealth visit with somebody who is in North Dakota. They have to be licensed in the state of Illinois to provide that care to you. So this is going to be important for us because, again, as in telehealth, you don't necessarily have to be in front of somebody. You can be in a completely other state. We just need to make sure that those licenses match up. We've also got into physical therapy, and we talked a little as we think about COVID. The people weren't coming to the office anymore. So here's the physical therapy compact. So how can you do treatment of a patient who is not in front of you, but maybe in another state, or maybe also in your state, but you still need to be able to provide that care. So this is the physical therapy compact. As you can see, we're making some progress in getting this moving along to different states. Each state has their own unique challenges that they face. It could be more territorial from the people who are providing the care within the state, don't want an external group to come in. That's something that we face. Or it just is getting people to feel comfortable with the concept. Not everybody before COVID, not everybody felt comfortable with telehealth. So if you come in and provide a public policy solution that may provide interstate compact, they might not feel comfortable with how that care is going to be provided. Another piece that, and this has another relevance to COVID as well, is the psychology interjurisdictional compact, which is provide telepsych. As you know, as we all know, COVID has kind of peeled back a lot of the issues, and we can see the underside of kind of our society that's really struggling right now, and with mental health issues. And so this is a way that we can provide care to people in different states. Now, one thing that this is pretty interesting, how the compact has showed some promise, has been more on the federal level. There's a bill called the TREAT Act at the federal level, which would allow during a public health emergency that there would be interstate licensure reciprocity in all states. And how that really started was around the mental health aspect, where kids who were getting care for mental health treatment at their university, but then went home because of COVID, or because of COVID were in need of mental health support. They couldn't provide that care because they weren't licensed in those states. So this is a way for us to be able to follow where the patient is and provide care where it is needed. There's one other piece, group that was not included. We also have the emergency, the EMS compact, which for those on border states is very important for being able to provide that care from transport to delivery at the hospital. So that's another piece that we're focused on. Before I get into COVID, why is this important? So why are these compacts important? Why is this medical licensure important? Well, there's a lot of reasons why it's important. And even before I get to COVID, I'll tell you the reasons why we got into this. One, it was a bureaucratic red tape issue for us. The time and energy it takes for us to provide care to get somebody licensed is extremely long, especially for an integrated health system. And so we wanted to make sure that we were being efficient with our patients, with our community's dollars, and not having to spend extra time and resources in getting people who are licensed in multi-states. We wanted to make sure that each state felt very comfortable in the licensure compact. And once that compact was in place and there was an agreement between the states, then they can move forward. We're also seeing a lot more mergers and acquisitions. So as you see, health systems are becoming more multi-state in nature. And then that dovetails into more narrow networks. So if you're a large integrated health system and you have maybe your own provider-owned health plan, now you have a narrow network. You might be also going into an ACO. You might have an at-risk arrangement for payment. Telehealth and that interstate licensure allows you to have that narrow network, but also be able to provide that care maybe at risk. So you can see if you're at risk for that patient and you're not getting paid anymore for having 5 or 10 telehealth visits, you're now being able to provide that care at home for that patient and keeping tabs on their health and well-being. So that's going to be another important piece. Another piece that's been interesting as well is and I think this is where our interstate collaborative might go to, is more integration of the rules and regulations across state lines. We saw this a lot, and I'll get into that a little bit with COVID, is around the different types of telehealth that's allowable. Some states, as Jess talked about, asynchronous visits. Some states allow that. Some states don't allow asynchronous telehealth visits. So it was about understanding what each state would be able to provide, what the scope of practice in each state would allow each provider to do. So there's some opportunities there. And then the last one, and I can't stress this one enough, and I kind of alluded to it when I talked about the Advanced Practice Nurse Compact, but we have a shortage in America in providers. And it's not just primary care providers, it's also, advanced practice nurses. It's about, urban, underserved urban areas. It's underserved rural areas where you're not going to be able to just find people and get them off the street and get them certified to become a provider. It takes time to get people up to speed and educated and licensed to be a provider. And I think as we get into COVID, post-COVID, the amount of people in our workforce that are going to retire is going to be significant. Even before COVID, those numbers were going to be significant. So how are we going to be able to leverage new technology? How are we going to be able to leverage the existing workforce into the future as we think about addressing the challenges in our communities and community health? So that takes us into COVID. So for 8 years, we ran this coalition. When I moved over to SSM, it kind of started to, it was handed off and it started to, I guess, kind of run out of steam a little bit. And then COVID happened, and we called the group back together and we started sharing resources and information. And how did this disruptive partnership help? Well, I think at the first call that we had was with Trinity Health. Trinity Health brought up on the call, they said, without this interstate medical license compact, without some of these other compacts that we had pushed for, they would have been swimming during the pandemic. So that reassured us that the work that we had done had been helpful. We were also able to share some resources. I got a lot of calls, a lot of emails from people about, what's the best executive order information that we could use in each state to address whether it was telehealth asynchronous visits, whether it was interstate licensure for people who may need to go to another state to help with the surge of cases. We were able to share that information in this disruptive partnership. And I think that helped a lot with the pandemic. And I think it's also going to allow us to continue to drive for more policy changes at federal level with Medicare, at state levels through Medicaid, and also in state level policy changes on scope of practice, licensure, and hoping to get more states to adopt the compacts or to allow for full scale reciprocity of licensure moving into the future. So I think COVID, as those of you who are in telehealth every single day, and Jess even had that document up with the timeline that showed, the first time that they were dealing with telehealth in 1994, and all the struggles that had gone along with public policy changes, with scope of practice, with licensure, with technology, and then all of a sudden you hit this night that is 2020 and the Band-Aid is completely ripped off, and now people, I think, are going to be are dealing with a different environment in terms of care. It's not just the millennials and the generation behind that are going to feel comfortable with telehealth visits. We have a whole new generation of people that now have gone through it, feel comfortable. They're not 100% there yet, but it's not something that they're going to be scared of moving into the future. So what's our look ahead for our group? Our look ahead is, I see it's going to be continue to drive towards public policy changes. The technology, I think, is there, and that's going to adapt. I think in terms of the licensure, we're going to get there. I think we have some work to do on advanced practice nurse practitioners. I think we have a physician assistant compact that may come in as well. I think we're seeing scope of practices, allowing people to do more at the top of their license. I think oversight of APRNs and PAs are going to continue to expand so that the ratio is higher. But I think where we're going to run into challenges, and this is where our group is going to need to be at, is how are we going to get paid for these services? We can have the best services in the world. We can have the best platforms in the world. But as we all know, the dollars are going to drive a lot of where we can be in the future, and what kind of risk do we want to take on. So I look forward to the future of the Interstate Healthcare Collaborative. I think it's only going to strengthen. And we don't necessarily lobby on things ourselves. We're there to share information. We know that there are groups that have difference of opinion on whether the federal government should have a little bit more oversight or the state should have more oversight, or what the scope of practice should be in each state. That's fine. But our job is to kind of bring the issues together, because there's strength in numbers. I'm not sure on where you all are from who are listening to this call, but if I'm in Western Wisconsin where Jess is, and I think to myself, I have this many House members in the state of Wisconsin, and we want to get a rural telehealth piece passed. Well, there's 40 plus members of the House in California. We're just outnumbered. So there's strength in numbers in terms of where you live, and finding like-minded partners who are doing it right. that you can work together on in changing the mindset and also ultimately changing public policy for the better into the future. So that's who we are. That's our group. And I have my email on the end. We have a once a month call if anybody's ever interested in joining the group. And the best part about it, the price is right. It's free. And we're there to share resources. And Mary has been kind enough to be on the agenda every month just to kind of give us an overview of hot topics in telehealth and share, because a lot of the group is around public policy. And it's always good for them to hear a little bit about what's really happening on the ground. What are some of the trends that we're seeing? So with that, that is my presentation. I appreciate everybody taking part in it today.
Wonderful. Well, Michael, thank you so very much. Appreciate the information and excuse me. And I guess to kick us off a little bit for Q&A, and just to remind everybody, you can do it. You can do one of two things. You can either enter your question in the chat in the platform here, or you can also unmute yourself and ask your question to kind of kick us off here a little bit. And I'll ask it kind of for both of you because you know the partnerships kind of evolved and came about differently. But if you were to pick one thing that you've identified really as being just your best success or your most positive component of the information that you shared today, of the organization or the partnership that came to be, what would you identify that to be? Jess, I'll start with you and I'll come to you, Michael, second.
I think what was enlightening to many people in the organization was that we thought that the people that were going to be seeking virtual care options were going to be the young, tech-savvy individuals. And in actuality, it was not. It was the octogenarians and older that were, taking out the iPad that they got for Christmas that they'd never unboxed. And they were the ones that were willing to do it and to learn. And so I think that was eye-opening for many here and very, our customer service team is so pleased when they can make that connection and see that person on the video screen. So, and everybody is happy and cheering, and it's a fun time. And I think that's what we found it very interesting and rewarding.
Wonderful, Michael.
I think what was and I owe a lot to my teammates. But I think one of the things that I'm most proud of, and if I were to ask my teammates this either here or at Gundersen when this started, is looking at that map of the Interstate Physician Medical License Compact and looking at it and say, you know what, we really started around pizza and having a conversation and really found some partners and was able to get to the point where, we can see patients now working across state lines without a problem. Like, perfect example, at Cardinal Glennon Children's Hospital in St. Louis, Missouri, during COVID, if I have a patient who is in East St. Louis that has kidney failure or renal or chronic kidney disease, and I don't want that child to come into the emergency room or even coming for a clinical visit during the pandemic because they're at risk. So now that provider can sit in St. Louis, Missouri, and have that interaction with that patient, once the compacts are in place, and not have to leave the comforts of their home and have a visual and engaging conversation with that patient and the family, and making sure that they're being kept safe and healthy. And we know that whether it's people who are living in rural areas that might not feel comfortable driving in a snowstorm, being able to stay in the comforts of their own home to get that care and not have to travel in. And even just in general, the peace of mind to know that you can pick up your mobile device. If your child has an ear infection and you're picking up, and you may not have the staffing at your integrated system in Wisconsin, but you're hearing from a provider in Oklahoma that's licensed in your state, and they're part of the same system, same medical record, and you're able to provide that care. I think just looking at the states that have adopted the compacts has really been a positive and rewarding for my career.
Thanks, Michael. Say one question for you. Because the collaborative is the members are kind of from all over and are often competitors themselves. Have you had any situation where that competition caused some challenges, or has it been fairly straightforward?
I think it's been fairly straightforward in terms of the competitors. I think everybody has their own niche, and again, I kind of alluded to that before. Some of this is around narrow networks of your health insurance plan. So you don't have the open networks that like you used to have anymore. And some of these services are insurance covered. Some of them are part of an employee package that you're providing. Either way, I think everybody is all about. We have a limited workforce. We want to make sure that we're keeping people as healthy as possible. And I think that the competition is only going to be the better for the patients at the end of the day. So we really have not run into too many problems. The one issue that we run into a little bit more than anything is about more of those groups that are not interstate, that are concerned from a protectionist standpoint that people are going to come in from out of state and provide care in their backyard. They can do it today. It just may take them 6 to 8 months to get licensed. This is just maybe just a little easier to get that license.
Great, thank you. Any questions from from the rest of the group?
I'd ask a question of the group if anybody wants to put anything in the chat box. Maybe put somebody on the hook for an answer, but or a question. But what do they see as the biggest challenge for telehealth public policy moving forward? Whether it's licensure or telehealth, what are the big challenges that they see moving forward in the future? And they can always email me or call me, but if they have a question, I'd be interested to hear what that is.
I'll wait the uncomfortable time.
That's all right. That's all right. That's why I threw it out there.
Let people kind of think about that a little bit. I think as certainly as COVID has created an awareness and an understanding of what this can be, I think our patients are going to continue to push us, and they're not going to understand why I can't see a patient, my provider in, I'm here just outside of Sioux Falls, and so in South Dakota we have kind of similar to your description. I can see Iowa from my backyard. Minnesota is a couple miles north. Nebraska is within an hour of us here. There are patients who come from all over and go to all over, and they aren't going to understand why this is a problem. And so I think that's maybe a thing that's going to push the healthcare policy side of things, at least from my perspective. Anna has jumped in and said, I think licensure of mid-level practitioners and and then I lost it. And exactly what is covered under various insurers is one of our biggest challenges.
Yeah, I would agree. And I think, like I said, when we started this process, it was all around in the physician license, which is, from a specialty standpoint, important. We run into that issue a lot with the children's hospital issues, where you have a very niche provider that may only be a handful of them across the country, right? That's an issue. But every day telehealth, that mid-level provider is going to be so important. And it's not just going to be around the APRN or the physician assistant once we start working on that compact, but I think there's going to be also the other groups, the occupational therapy, the physical therapy, the other services that are provided once they're able to figure out how to provide that care well in that in-home setting is going to be a game changer, especially for care. And then it's going to also open up the opportunity, I believe, for primary care then to focus on, really diabetes management or, chronic disease management in the office setting, where the other pieces and people feel comfortable with that, the ear infection, the UTI, the other stuff that can be handled, whether through a digital platform, consumer-based pieces, we'll be able to manage that a little bit easier.
Yeah, I agree. Any other questions from the group, from our attendees? Jess, any last words?
No, I thank you all for joining us, and please reach out to me if you have any questions about our virtual care team or our plans for the future. So happy to collaborate always. So thank you all for coming.
I would say the only thing is that, if in the telehealth space, in the interstate licensure space, I think the most important thing that we can focus on is ensuring that a lot of this flexibility remains intact for the future, and that you stay engaged, because if you're not engaged in this process, we may lose out on some of those flexibilities. Feel free to reach out to me at any point in time. Be happy to help out, and appreciate your interest in this topic today.
Wonderful. Thank you both for taking the time to share your experiences with us, and know that you are also able to reach out to not only through the emails that they shared on their information, but also through the conference platform. You can always reach out to them as well. But know that I know both of them well, and they're both very willing and capable of interacting and sharing information with you all. So bunch of good folks. So thank you all for joining us today. And if there aren't any other questions, oh yes, thank you for that reminder. We have make sure to complete your session evaluation. That's an important piece, and learning from the side of the conference planners. We really do take that to heart, and thank you for your thoughts and your evaluation around that. So unless there's any other questions. All right. Thank you all for attending.